My wife was pregnant with our second child. We knew it was going to be a boy. Drove my wife to the hospital. I think I got there at about 6 o'clock, which was just in time because Joshua was born at exactly 7:38 on that Monday morning. And when he was born, my reaction was, thank goodness he was just a perfect, healthy, beautiful little baby boy. It was about 30 minutes later that things started to go wrong. He had a low temperature, he wasn't breathing properly, he was reluctant to feed. But at the time, we were just reassured, he's a little bit premature, all these things are normal. The next day, it was obvious he was a very poorly baby at that point. He was transferred to Manchester by ambulance. The team in Manchester told us, actually the only thing wrong with Joshua is he's had an overwhelming infection and he's suffering from sepsis. We kept thinking, Joshua is here for that basic lack of care that he could have had in the first hour of his life, and he wouldn't be here at all. He was actually flown by helicopter from Manchester to the Freeman Hospital in Newcastle, and that's when we were advised about this treatment called ECMO, basically a heart and lung machine for babies. Unknown at the time, his left lung began to bleed because it was more damaged than anyone realised. And the consultant had a conversation with my wife and I and said, look, if we tried this operation, it'll be futile, and we just worried it will make him suffer more. So on the 5th of November, the consultant said he's going to turn the ECMO machine off. And he went away. 20 minutes later, it came back, and we said, he's gone, hasn't he? And the consultant nodded his head. And Joshua had died. I think the first time, actually, at that point, we'd seen him without all the tubes and all the equipment, and he just looked like the perfect baby boy. We said goodbye to him, and the hardest moment of my life, without a doubt, the hardest moment. What I remember thinking was, if Joshua's care was this bad, if he had so many obvious signs that he was poorly, and he was just left until he collapsed, is it just him? Or could this have happened to other babies? What we know is that there were huge discrepancies between what the midwives had reported and what my wife and I remember happening. I'd actually met a number of other families. These are families that had lost babies. It seemed that the pattern of what happened was very, very familiar, so doctors not being called, investigations that covered up what happened. In early 2013, I met the health secretary at the time, Jeremy Hunt. He agreed to hold an independent investigation, and it found a lethal mix of failures, and the words in the report were that we have no doubt led to the preventable death of mothers and babies. And they found that 16 babies and 3 mothers had died following poor care, and of those, 11 would have almost certainly survived with the right care. And the tragedy, really, for me, is 6 of those baby deaths happened after Joshua died. The whole management of the trust for years and years, denying that there were any problems, using statistics to paint a picture of a very safe maternity unit. They described that as an ongoing cover-up. And this became the headlines in England for over a week. There's no doubt to my mind that those records didn't vanish by accident. Somebody took those medical records and made a decision that it was better to get rid of them than to present the evidence. My reflection very much was, why didn't they learn from this?
And you realise that we've got the culture wrong in healthcare. We just make it too hard for people to admit to ordinary human error, whereas things like the airline industry, the oil industry, the nuclear industry, they have all learned that they need to make it easy for people to admit when they made a mistake so that they can then develop the systems that prevent those mistakes being repeated.
And there's a real danger, I think, of people using high-level data to misrepresent and using data for assurance rather than actually what can we learn from this.
Because if you don't quantify the problem, we won't get action to change it.
And we've got to have that honesty and that candour to address problems. I wish I could turn back the clock. I can't do that. I can't change things for him. But I do think his life hasn't been in vain. And I think there is a legacy for him, and hopefully that legacy is safer maternity care. And I think he's played a small part in helping that happen.
It's a privilege to speak to your conference today. I'm sorry I can't be with you in person, but it's a double privilege to come after the video you've just seen of James Titcombe, because when I became Health Secretary in 2012 in the UK, I really have very little idea about health. I was right at the top of this huge pyramid, the 5th largest organisation in the world, which is what the NHS is. And I had no idea what it was like for people at the bottom of that pyramid, people like James, who had to write more than 400 emails before the NHS would admit what went wrong in Joshua's care. There was I sat right at the top of the pyramid. It wasn't until I met James and a number of other families that I began to realise that things had gone radically wrong. And that really started me on my patient safety journey, which has taken me a long way. But in the process, my thinking has evolved and developed. I started off thinking that the biggest challenge with patient safety is transparency, and the tendency that we have in modern healthcare systems to cover things up when things go wrong. Often for very understandable reasons. It's incredibly difficult psychologically to deal with the fact that you may have been responsible for someone else's death. No one goes into healthcare intending that to happen. And so very often there's a kind of pressure not to confront something that might have happened. Sometimes that can be caused by lawyers. Sometimes it's just how it is. And so I felt transparency was the first thing. I spearheaded a number of initiatives to bring transparency to patient safety issues, including independent rating of all hospitals in the UK for their safety and quality, including introducing a legal duty of candour on all hospitals when a patient has been harmed, to be honest about it with them and their families. We introduced a huge maternity safety programme aiming to halve the number of neonatal deaths, maternity deaths, neonatal injuries and stillbirths over a period of 10 years. We set up a new body that did airline-style no-blame investigations. And all these initiatives helped make important progress. By the time I finished, after 6 years as Health Secretary, 3 million more patients were being looked after in hospitals that were independently rated as good or outstanding. We had, over the course of the last decade, we have reduced the number of neonatal deaths by 30%, the number of stillbirths by 25%. So there have been some very important improvements. But the more I reflected on the challenge, the more I realised that the real change can't be top down. It can't be because a Secretary of State or a leader decides to impose change on a large organisation. There has to be cultural change that comes from inside. And at the heart of this is the fundamental problem in modern healthcare systems that we're not very good at learning from mistakes. You compare that to other industries like the airline industry, the oil industry, the nuclear industry, that have all developed systems to make sure they really do learn from mistakes, and openly aim for zero accidents, zero mistakes, zero harm. We have a long, long way to go in healthcare. We know that in the NHS in England alone, we have 150 avoidable deaths every week, and that is, pre-pandemic, normal times number, but that is the equivalent of one aeroplane falling out of the sky every single week just in the NHS in England. We know that the rates are similar in countries like Holland and Canada, and indeed throughout the world. And really, what this is about is understanding that doctors and nurses are human beings who make mistakes too. They are particularly brave because they go into a profession where the price of those ordinary human errors can sometimes be a tragedy, a fatality. But we need to find a way to differentiate between the ordinary human mistakes that we all make, that we need to be open about and learn from, and gross negligence, the egregious errors that should never be tolerated. And that's what's happened in the airline industry. If you turn up to fly a plane drunk, you'll lose your license and you'll never get it back and you'll be drummed out of your job. But if, on the other hand, you forget to do check number 48 of 71 checks, then people look at the system-wide reason why that mistake was made, and they try to rebuild systems so that that mistake is not made again. And we haven't yet learnt to do that in healthcare. So this is really about cultural change. It's not going to happen overnight, but I was also UK Foreign Secretary, and I always remember what one of the most respected diplomats in the world, Dr. Henry Kissinger, what he said about diplomacy. He said diplomacy is the patient accumulation of partial successes. Well, it's the same in patient safety. We should not be disappointed that the success is partial, and nor should we underestimate the amount of success we can achieve if we're patient. And someone who knows about this far more than me is your next speaker, Professor Albert Wu from Johns Hopkins University, someone who I am a huge admirer of. He is the person who coined the phrase second victim to describe the fact that clinicians too are victims when there is a tragedy. And we need to remember that and support them to be transparent and to learn from those tragedies, just as we need to support families who experience them. He's also editor of the Journal of Patient Safety and Risk Management. So it gives me great pleasure to introduce him and to thank you all for the incredibly important work you are doing in patient safety.
Thank you very much, Jeremy. Well, I'd like to begin by introducing today's panelists. Diane Perez, could you introduce yourself briefly?
Sure, Albert. Hello, everyone. I'm Diane Perez. I'm a physician and journalist. I'm a news anchor and medical correspondent for Televisa.
And Ariane Marie Mitchell, also, can you introduce yourself?
Sure. I am a faculty member in the Preventive Medicine and Pediatrics departments at Loma Linda University. I am also the medical director for health equity for the Children's Hospital.
Thank you. And Raj Ratwani?
Thank you, Albert. Nice to be here. I'm Raj Ratwani. I serve as the director for the MedStar Health National Center for Human Factors in Healthcare, and also the vice president of scientific affairs for the MedStar Health Research Institute.
Thank you all. I'm looking forward to a really great discussion. So James's tragic story highlights the need for greater openness about the inevitability of error and the ever-present potential for harm in healthcare. Greater awareness and acceptance of human fallibility is really needed for the entire system to be able to improve and become safer. As humans, when something goes wrong, our first instinct is to blame. But we have learned since then that it's the system that really causes hazards and creates safety. I guess one could ask, what do we mean when we say the system? And what are system factors? Who are all the players who shape how care unfolds? Raj, can you enlighten us?
Yeah, happy to. Albert, I think as you described, when we think about the care process, I think the first thing that often comes to mind is the patient, the doctor, the nurse. We probably think about the family. We probably think about the caregiver. But we know it's much more complex than that. And so we often describe the healthcare landscape as a system. And when we say system, what we mean are all the different components that impact the care process. Some of those are very obvious, like people, the people we just talked about. And then there are some not so obvious ones. There's things like the technology, medical devices, the electronic health record. There's equipment, the beds, there's other supplies. There's the processes that are happening between people and the technology. And then, of course, there's things like culture and policies. So these are all different components of what we call that system. And each of those components interact, and each of those components can contribute to the types of horrific errors that we just saw. And so for us to really tackle safety, we need to consider all these different system factors. We need to consider how they interact, and we need to look at how those system factors contribute to errors so that we can actually mitigate risk and make improvements.
Thanks very much. That was very clear. And we have learned, of course, that there are factors that can contribute to errors and harm at every level of the system. Indeed, we've learned that safety is consistently improved when patients and families are actively included as members of the team. But this doesn't always happen. Ariane, can you tell us what do you see as the biggest barrier to this actually happening, to patients and families being included as members of the team?
I think there are several barriers that come to mind. One is just often our visits with patients are very time pressured. And often our staff are stressed for a variety of reasons, including that time pressure. And often we're not well trained in how to communicate in a way that fosters listening. So I think all of those things contribute. But if I thought a little bit more about the biggest barrier, I would have to say it's how we think about healthcare services. So right now, our healthcare systems are designed around the idea that healthcare is something that we do to someone. We need to redesign our systems around the idea that healthcare is something we do with someone. If that perspective shift were made at every level of the system, from the front desk to the most senior executive and all the processes in between, then inclusion would be recognized as integral to patient safety and would naturally lead to elevating the importance of reducing time pressure, reducing staff stress, and prioritizing communication.
Well, even though there's a lot of talk about being patient-centered, I guess our system is still pretty clinician-centered. So how did that happen? What role has the health industry played in preventing patients and families from becoming meaningful partners? Diane, can you shed some light on this?
Sure. I believe this is a shared responsibility, Albert. Patient safety is not about finding who is guilty or blaming health professionals for malpractice, but to understand that the issue might have happened because the health system, very well described by Raj, has failed. We need transparency from health professionals and institutions to be able to find and correct possible implementation errors that could lead to tragic situations. Including the patient and his family is also a key element to reach the best results with the treatment. And this could also involve cultural aspects. For example, in Latin American countries like Mexico, It is very common to see family members going to the doctor with the patient, although this does not necessarily mean that the family member will be actively involved in the patient's treatment. I think there are three main points that need to be emphasized: transparency, inclusion of patient and family, and also technology, automation of processes in order to reduce human error.
Well, I think all of those 3 points are important. I'd like to focus for a second on transparency, or as they say in the United Kingdom, being open. So there are a lot of barriers, it seems, to health workers being open about all the things that might and sometimes do go wrong. How do we start to remove those barriers to being open? Raj, can you help us with this?
I'm happy to chime in first on this, but I'd open this up to several of the panel members here because I don't know that we have the exact right answer. And certainly if we did, I would hope that we would have implemented it by now. So I think there's probably going to be a lot of strong thoughts by panelists here. So let me start. I think there's a couple elements that come to mind right away. The first is culture change. And this has to be both a top-down and bottom-up process. So we've heard time and time again how culture can be shaped by leadership style. That's absolutely true. And we need key leaders to understand the importance of openness and the implications that that's going to have for safety. But this is also a bottom-up process, or can be a grassroots process, where frontline nurses, clinicians, patients, family members can keep pushing and championing for this so that it influences the rest of the organization. So I think that's a critical process here. The other important thing that I would highlight is alignment of incentives. And we see this so often in healthcare, where incentives are just misaligned, and it leads to this kind of secrecy or closed environments, the opposite of what we're trying to go for with openness. And I'll give you a concrete example of this. If you look at many of, at least in the United States, if you look at many of the contracts between EHR vendor companies or other technology developers and healthcare facilities, there's often what's called a hold harmless clause. And this clause essentially shields some of those companies from any ramifications of malfunctioning technology and harm that may then occur. So you can see how that's a really big misaligned incentive in terms of delivering safe care to patients. If there was to be a tragic event related to that technology, there's not necessarily a strong incentive for that technology developer to now make improvements because they're shielded from so much that happens with the technology. And so that's just one example. There's many, many examples like this. And until we get that alignment of incentives, it's going to be really difficult to have these open conversations that we want to have.
So Raj, I think you covered it. Oh, Diane, please go ahead.
Oh, thank you, Albert. Here, I think that the regulations in each country are fundamental. In some countries, doctors who make a mistake are punished, although they did not cause intentional harm. And I believe that must be changed from a legal perspective.
Oh, great point. And Ariana, I want to give you a chance now, since our other two panelists have weighed in.
Oh, I think I concur with all that they said, and would go back to some of the things I said at the beginning about really just needing to change the system to focus on working with people. And if we put that emphasis on what matters to patients and families, it drives those kind of policy changes and culture changes that we need.
Great answers. Thank you. So even in the best healthcare systems in the world, there are still inequities in the quality and safety of healthcare, even within single institutions. This is obviously not right, but what can we do to eliminate them? Ariane, can we get you again?
Yes, absolutely. It's a topic I care a lot about, and I would give sort of two general answers. I would describe the changes that are needed on an individual level and on an organizational level. So on an individual level, staff education about societal oppressions and how they lead to inequities is key to increasing understanding, generating dialogue, and initiate the kind of changes that we need to improve our outcomes. So that education should focus on raising awareness. How is my lived experience different than the lived experience of someone else? And it also includes being aware of how implicit or unconscious bias may influence all of us in our interactions and decisions. So that would be staff education on an individual level as part of the answer. And second component is that organizational level change. So healthcare systems need to examine potential disparities in outcomes they are producing. As I've gotten involved in this work, I've just been surprised that just hasn't been the standard to date. We've looked at our outcomes, but we've not necessarily looked at our outcomes by different demographics. And if we don't look, we don't know if there are disparities. So disparities would be population level differences in outcomes that are related to a history of disadvantage that is based on societal constructs. In other words, based on something that's not inevitable. So therefore, it's something that we can potentially prevent. And when we identify those disparities, which we surely will, because we know that that's part of the society that we live in, when we identify, then engaging a wide range of stakeholders is really key to designing effective solutions. And of course, that's got to include members of the community that are being served. So for example, in our work at Loma Linda, to promote health equity, key components of that include staff education. We have a task force that's focused on measuring our health outcomes and looking at potential differences by demographics. And we are soliciting community feedback from our patients and families.
Albert, if I just may quickly add 2 points to those really important points that we just brought up. I think one thing that is critical here and is missing is the feedback loop. So if you think about implicit bias and some of the subconscious processes that are happening, there's no doubt that what was just highlighted in terms of education and knowledge is critically important. But what we also know about performance improvement is that you need immediate feedback, and it's got to be just in time. It has to be within a short window of the occurrence of the event. And so until we're able to create the methods and processes to quickly identify these point-by-point health equity issues and these biases and give that feedback directly to those that are committing them, it's going to be difficult to make the widespread improvements that I think we're all hoping for.
So interestingly, this is a problem of transparency too, but it's transparency or communication within the healthcare team, perhaps at different levels. And if you see something, as the expression goes, you should say something, whether it has to do with a medical error or perhaps some other error in the communication process. Now, all that said, we all, patients and families included, we all have great expectations for healthcare, particularly our own personal healthcare. We all hope for the best, even to the extent of ignoring the fact that things can go wrong. Now, on the other hand, we read, maybe not every day, but every week or every month in the newspapers, we hear in the media about terrible things that went wrong. There seems to be a little disconnect. Diane, can you help us understand what role does the media play in this problem? And maybe a harder question, how can the media help to improve the situation?
Thank you, Albert. I love this question. I love this topic. And well, it's a fact that when you go to the doctor, you expect to be cured, and you rarely think that something might go wrong. So the media generally publishes either great advances related to science and technology, or, as you said, huge tragedies when something goes wrong, especially when it relates to a public figure. Although this is necessary from an informative point of view, the media also needs to share educational information related to patient safety. It is okay to tell stories about success and failure, but always we have to give a choice to all the parties involved and try at the end to send a positive message. The media definitely plays a huge role in changing behaviors in society. We have seen that many times, and could be used to include patient safety issues in soap operas, for example, in TV series, sharing information about what can be done to obtain the best results in healthcare. Of course, we also must consider social media, but it could result in a double-edged sword due to poor self-regulation now in the case of social media. But undoubtedly, social media is also a very powerful tool to contribute to patient safety.
I'm glad you brought up the last points. And in fact, the people who are exercising social media are humans too.
Mm-hmm.
A human thing, I mentioned earlier, a human behavior is we tend to blame or look for someone to blame when something goes wrong. So a really difficult question, I think, is how can we change that culture of blame? If you are a worker and feel like that you will be blamed and shamed and punished for talking about things that have gone wrong or could go wrong, then you're not going to talk very much. So Ariane, can you help us? What can we do to make people feel safer, to reduce that fear of being open, and to reduce the cover-ups that result as a result, as they did in James's story?
So a couple thoughts come to mind. I'll first sort of acknowledge what Raj said earlier about the importance of culture change involving the whole system. And often the emphasis is on leadership, but we need all individuals in the system involved. So I absolutely agree with that. Having said that, I'm going to focus my statements on leadership because they really, really are central. So perhaps the most important thing, in my opinion, that leadership can do is model the change they want to see in their organization. So if they want their staff to show empathy with their patients, then they need to show empathy with their staff. If they want their staff to listen to their patients, then they need to listen to their staff. And perhaps one of the most challenging for many of us. But if we want our staff to prioritize self-care so that they can show up at work being the best possible people that they can be to do that work, then leadership needs to model self-care. The second aspect that I would say that is important for leadership to do is to drive the focus on patient-centered outcomes. And this might be the researcher and me talking, but I just think what we measure matters, and leadership drives that. So don't just talk about the value of patient experience, but measure patient experience and focus on improving patient experience. And that's going to require talking with patients from different demographic groups, and especially talk to patients who have a social disadvantage of for one reason or another. Listening to and incorporating feedback from the most disadvantaged patients will improve care for all of our patients.
I think that what you say is very true. Raj, can you talk for a second about how we can suppress our instinct to look for blame and to make it safer to be open?
I think, Albert, you sort of call this out. I think it's so innate for us to think about an individual to blame. We're generally linear thinkers. It's very difficult for us to think about system factors and all those contributions and how those might interact. It gets really complex. And, one thing leads to another thing, and that causes this error. One thing that I've seen work is to really come up with good use cases or illustrations of how these things unfold. So if we can show how, the poor design of a piece of technology is what actually contributed to the error, rather than looking at the individual, blaming that person for using the technology wrong. I think it's those kinds of examples that help shift the culture. It helps us think about what are the other system factors in the environment that might be contributing to these issues. So I think, I like these comments around leadership and highlighting those pieces. This is another one where I think leadership can start to highlight some of the contributing system factors and start thinking about all of the other players and stakeholders in the environment that we need to work with. And I think Diane early on called out shared responsibility. I think that's critical to this. So I think use cases would be the punchline for me is clear illustrations of system contributions.
And a very practical punchline, I think. So Diane, the media has an instinct to find a good story. How can we get to the leadership of media institutions to perhaps get them to suppress that instinct long enough to provide a more balanced picture? Perhaps, how do we train them?
Yeah, it's hard because, of course, media is looking for rating, and rating is given by big things. And unfortunately, bad things attract more attention than the good news. So that's also one point that we need to fight in the media. But we definitely need to have a focus on education and empowering the patients and show people that they have a responsibility when it comes to healthcare. They have to be involved, and family members need to be involved with what's happening with their loved ones. So I think their media can do a lot, and not necessarily only in the news shows, which is my expertise, but also, as I said, in soap operas or TV series. We need to include these topics of patient safety in those that attract people in a very light way, and they can pay attention to it and realize that they, as patients, can have an important role in their healthcare.
So we need more telenovelas that
exactly.
Tell this story also.
Exactly.
Well, this has been a great discussion. I feel like we could talk about this, go on talking about this for hours, and with experts like the three of you, I suspect you'd be very happy to join up. But in summary, I see that we really do have a problem. And the problem is perhaps, the biggest problem perhaps is with changing our culture and being truthful with ourselves. I think that we need to think more about how we can face the truth about patient safety, and the fact that the truth is that care is not always safe. How can we get people to acknowledge that truth? Ariane, how can we persuade people to acknowledge this without scaring them off so that they run away from healthcare, and in fact, we wind up decreasing access instead of, and perhaps reduce equity, create inequities? How do we?
Yeah, I mean, it's a difficult problem. I think as you were talking, I think there is not exactly the same thing, but a parallel to talking, for example, about the topic of racism, where it's a difficult topic. But part of what I have found helpful to acknowledge the influence of race and culture on our society is to recognize that we're not trying to identify the baddies, the racists, so to speak, right? We're trying to recognize that, for example, that we all have biases that we have grown up with, that from the day we were born, we are being taught about these biases, and that these influence us, and that these are part of our system. And so it's about recognizing that we all want to be treated with love and respect and receive good medical care. And how do we get to that common goal, right? So I guess the parallel to me with patient safety and errors is, again, we're not trying to identify the baddies, right? We're trying to recognize that there are aspects of literally how we are designed as human beings that contribute to the potential error. There are aspects of our systems that we have built that can contribute to patient error. And so how do we all rally around what we all want, a just and fair and society, a safe and equitable healthcare system? How do we rally around that? Partly by recognizing the role that we can all potentially play in improving it.
Well, that's great. Thank you. I think that we really are not interested anymore in finding the bad apples and throwing them out. But circling back to the video that featured James Titcomb, we learned that that workers at many levels at Morecambe Bay felt inhibited and really had information but didn't speak up, didn't come forward, and as a result, this perpetuated this pattern of substandard care, and in fact, the tragic deaths of many children. Raj, how do we convince clinicians, doctors, nurses, and others that that we're not interested in blaming them, that it's safe and in fact even desirable for them to talk about things that go wrong?
Yeah, it's a great question. I think first is asking the question why. So as we watch that video, why is there this move to cover things up? What's the incentive to do that? And I generally don't believe that they're malicious actors. I believe that in their minds, there's some reason why they can't talk about this openly. It could be repercussions from leadership. It could be financial penalties. It's a whole host of factors. So I think we have to first understand the why, and we can make some good guesses as to what those are. But in every situation, I think we have to think about that individual or that group and think about the why, and then I think it's important to come back to culture and to help people realize that the only way to improve, and we should all be incentivized to improve, the only way to make improvements is by these open discussions, is by identifying the system factors and coming back to those system factors to make improvements. And it comes back to the top of this conversation at the very beginning. We talked about being patient-centered and always striving to do what's best for the patient. And we have to make sure that, again, all those incentives are aligned so that we're there to deliver the best care possible and everybody's moving towards that goal. I'm sure Diane may have some other comments here and thoughts on that, so I turn it to you.
Yes, Raj, I agree with you. I think culturally competent care is something very important. I see people who go to the doctor, how they react in Mexico versus how people go to the doctor and react here. I mean, I think we need to empower the patients to not be ashamed when they are with their healthcare provider, and feel free to ask questions. I have seen horrible stories in Mexico of people who do not understand what the doctor is saying and do not understand, for example, the prescription. And well, in some countries like Mexico, for example, where prescriptions are not automized as here, unfortunately, you go to the doctor sometimes and the doctor writes it, and we are famous for not having a very nice writing way. And sometimes the pharmacist does not understand, and the drug delivered is something different and has also secondary reactions that are not the expected. So I think it's very important to empower patients to not feel ashamed to ask questions when they do not understand something, and also to try to educate healthcare providers to make sure that the patient really understood what they need to do and really understand what kind of medication they are receiving. So again, I think this has to be very different and very customized in every country, so it can be really, really effective.
If I could just make a quick comment on that. So I was listening to a community health worker sharing a story about a Spanish-speaking patient. She also spoke some English, but she asked the nurse if she could have a translator because she wanted to really make sure that she understood what was being communicated. And the nurse responded with like an eye roll and a, like kind of, right. So this is a microscopic little interaction, a little story that I heard about. And so it's easy to, be outside and say, gosh, what's wrong with that nurse? Why didn't she respond with more compassion? And, right. And I'll bet you if I were to pull that nurse aside outside of that situation and talk about culturally competent care, she'd say, of course, everybody should have a translate, right? But the thing is, we get into these situations because very often, she was stressed, she was tired. I'm just thinking about things from the nurse's perspective. And that's where I think, the full, answer to design a safe healthcare system really is recognizing all those players in there. And it is about it to get to patient safety. It's about creating staff wellness as well, creating that's getting at that culture. So.
And if I just may add to that, I think that's an incredible story and such a great example. And I started by saying let's look at the why. So if we dug into that further, just as you were, we could all come up with some hypotheses as to why the nurse may be reacting that way. From what I've seen in certain care environments, it could be that there are very few translators, and the wait time increase by asking for a translator is significant. And you had talked about the time pressures here, so this is adding to the time pressures. We've seen that some of the translation technology is not always fully functional and has all kinds of issues that arise. And so you can imagine the stress that comes on to not only to the nurse, but the care team if you dig into that system factor of technology. And so I think it's such a wonderful story because it highlights how we turn to thinking about that nurse as probably being not a very nice individual, not caring about equitable care, but a layer underneath are all of these system factors around technology, workflow processes, et cetera, that contribute to this. And I would wager that probably most of us in that nurse's shoes would probably act the same way, given all of those constraints. And so we really need to think about how do we alleviate those system factors. I think such a great story that you brought up.
So, Diane, you sort of sit in between in some ways, all of the worlds. But I think that we've heard about sort of the importance of the perspective from perhaps the bottom of the system or the base of the system, patients and families and providers. How do we educate leaders to encourage everyone to be more open, to speak up when they see something or think something is happening, all the way down to patients who shouldn't just ask questions about their own care, but should be volunteering their perspective about the quality of care that they're getting. How can we convince those people at the top?
Well, I think education, and of course, media's responsibility is not to educate, but we still have the duty of providing that information. So I think media can help very much in this sense. And also all these truthful sources of information, like the patient safety movement, for example. It's great to have these tools where people can consult and have access to all that information. And this patient aider, for example, app of patient safety that the people can read and can really get confident with all what's going to happen if they go to the hospital and know what to expect. Because unfortunately, when patients go to the hospital, most of the time they just don't know what to expect, and they try to believe the people they understand the more, which probably are not the healthcare providers, but maybe an assistant that is filling all the forms or a receptionist, and they get close to that person because they feel that person equal to them. So what we need is first to try to lower the healthcare providers, nurses, doctors, technicians, to the patient's vocabulary, and then also give tools to that patient to be able to understand what the healthcare provider is telling them. No? So to have this communication among patient and healthcare provider that flows easily in order to get the best result.
I'm really glad that you got us around to tools, because many people have all up and down the system have good intentions, but don't know how to take action to do the things that they understand they need to do. There are many free healthcare safety resources that are available for clinicians, for administrators and leaders, and for patients and families. Many of them, in fact, are on the Patient Safety Movement Foundation's website. Anyone viewing this this panel can, I hope, will go sometime after and just look around a little bit and see what is available there. I'm going to ask for one line of one-line piece of advice or action from each of you. Raj, if you had a one-liner, what advice would you give?
My one-liner would be to make sure that as a patient, you have a champion on your side, a family member, a loved one, a caregiver. Got to have a champion on your side. There's
strength in numbers.
Yep.
Ariane, what would you say?
Albert, this is really unfair of you to take a very complex topic and make us reduce it to one line at the very end. I will simply say, I'll say one word, which is listen, or learn how to listen. It's not easy, but it's important.
Oh, you've done really well, though. So despite the unfairness of my question. And Diane?
I believe Ariane says, listen to the healthcare provider, and I would tell the patient and the patient's family to be curious and to reach out to truthful sources in order to find the information that can help them lead with the disease.
Well, thank you for your one-liners of wisdom, but also for all of your thoughts and comments over the last hour. I've learned a lot. I feel smarter now than I did an hour ago. Thank you very much to all of our panelists, and thank you to our audience for your attention. Thank you all for joining.
Hello, I'm Marty Hatley, President and CEO of Project Patient Care. I'm a patient safety advocate and serve on the board of directors of the Patient Safety Movement Foundation. I'm also a World Health Organization Patients for Patient Safety champion and serve on the steering committee of the Patients for Patient Safety Network. It's my pleasure today to introduce Dr. Jeff Brady, who is the director of AHRQ's Center for Quality Improvement and Patient Safety. He's served in that role since 2014. Prior to that, he led the AHRQ Patient Safety Research Program, and prior to that, he led the agency's work on producing the National Healthcare Quality and Disparities Report. So a long and distinguished history on top of earlier service to the country as a physician and epidemiologist in the military. He's now on the AHRQ senior leadership team that oversees patient safety research, the PSO program, and the Healthcare Associated Infections Prevention program of AHRQ. Jeff, AHRQ is the leading research engine in the world on patient safety, and your agency has been prolific in evidence-based tool development and identification of best practices. In your view, what's driving patient safety now? And will you speak to Safer Together, the National Action Plan for Patient Safety that AHRQ published last year on World Patient Safety Day?
Well, thank you, Marty, and thanks to the Patient Safety Movement Foundation for your work to promote patient safety. There's a lot happening in patient safety, and we can all appreciate that many more things still need to happen. The COVID pandemic has served as a real-life stress test for healthcare, and it's called attention to some of the weaknesses in our systems. But thankfully, in other cases, we've also seen the value of resiliency and the benefits of well-designed system-based care. The concept of high reliability organizations has also been a positive influence on safety, and organizations embracing these principles are successfully overcoming some very substantial threats to safe care. Safety is very personal to all of us. Patients and their families expect expect safe care, and clinicians want to provide care that's safe. Clinicians also need to know that their own safety is a priority. I want to be sure to acknowledge the hard work that so many are doing to keep patients and healthcare workers safe. We most often see progress when that shared purpose and our hard work and dedication draw on what the field has learned from research and the effective use of data to understand safety threats. It's tempting to oversimplify and underestimate threats to safety. We know that unfortunately, healthcare can harm patients in many different ways, whether it's harm to a mother or a newborn during childbirth, or an avoidable harm from a fall, medication error, healthcare associated infection, diagnostic error, or one of several other types of events. The full array of safety threats is not always straightforward. We can be faced with confusing mixes of patient, clinician, organizational, and other features, all interacting in complex ways. As healthcare evolves, so can the risks and hazards. Safe healthcare organizations understand this challenge, and they provide the resources and capabilities to monitor for adverse events and outcomes and to respond confidently with well-designed safety changes that will help prevent harm. Before the pandemic, the Institute for Healthcare Improvement convened a US-based committee to develop a national action plan for patient safety. It was my privilege to co-chair the steering committee with my colleague, Dr. Tejal Gandhi. We were joined by many experts from more than 30 organizations who contributed their collective wisdom to developing the national action plan that we released last fall. The plan emphasizes the importance of foundational factors that must be in place for safe care. Those factors are culture, leadership, and governance, patient and family engagement, learning systems to better understand patient safety and guide improvements, and the safety of the healthcare workforce. We have come to appreciate that these factors are prerequisites for safety, since they are common elements that enable almost all improvement efforts. The plan has 17 recommendations based on these foundational factors, with the intent of moving from concepts to capabilities by establishing strong systems that will support the implementation of safe practices for better care, such as those we summarize in the AHRQ Evidence Synthesis Series, Making Healthcare Safer. The combined effects of foundational factors and proven safe practices can have profoundly positive effects on safety. Working together in several dimensions is essential for progress. We see the value of effective teamwork among clinical teams, patients, and their families. It's also important for leaders in healthcare to support the work of clinicians and their organizations with robust learning systems that harness a wide range of data and novel analytic capabilities to guide this critical work. Finally, we must improve our ability to learn together and share the lessons that research, practice, and implementation science teach us. Collectively, we've seen that when we do this well across organizational and other boundaries, it can have profoundly positive effects that keep patients safe. Safety is central to our mission at AHRQ, and I'd like to take this opportunity to thank everyone who's working to keep patients and healthcare workers safe.
Thanks, Jeff. And thanks for everything you and your colleagues at HRQ do to inform the field, equip us with tools, drive change, and prevent harm to patients and families. Paul Tang is an adjunct professor in the Clinical Excellence Research Center at Stanford University and an internist at the Palo Alto Medical Foundation. He has over 25 years of executive leadership experience in health information technology within medical groups, health systems, and corporate settings. He has directed innovation and technology teams in provider organizations, academic institutions, corporate research organizations, and the product development sphere. Dr. Tang is an elected member of the National Academy of Medicine and has served on numerous study committees there, including a patient safety committee he chaired that published 2 reports, Patient Safety, A New Standard for Care, and Key Capabilities of an Electronic Health Record System. He's a member of the Health and Medical Division Committee of the National Academies of Science, Engineering, and Medicine, and he's the co-chair of the Federal Health Information Technology Policy Committee from 2009 to 2017. Dr. Tang, you're an editor on a recent National Academy of Sciences peer review report on strategies to improve patient safety. That report analyzed progress since the first IOM call to action on patient safety in 1999 and the passage of the Patient Safety Quality Improvement Act of 2005. That law created the national infrastructure for patient safety organizations to use data to drive improvement in the United States. And it raised a lot of hopes and expectations for big leaps forward in preventing harm. Paul, in your view, how are we doing so far? And what are the opportunities you see going forward?
Well, thanks, Marty. I want to start out by thanking this wonderful coalition that's championing this important cause, because I think we're at a tipping point. I think we have a glass half full opportunity. So if you think of it, in 1999, the publication of the Institute of Medicine's To Err's Human Report raised the public's and frankly the healthcare workers' level of awareness of patient safety imperative. But the reason we're all here at this summit today, 20 years later, is really, I don't think any of us are satisfied with the progress we've made to date. We often hold the aviation industry as an exemplar of high safety and high reliability. And there are many reasons for that. One is they have very visible and transparent failures, but also from a learning point of view, aviation safety relies on standardized mandatory electronic data collection systems, and they have a robust legally protected analysis and recommendation process. That helps them continually improve and makes flying safer every year. Now, at the time the IOM report was issued, we did not have that in healthcare. We didn't have a data infrastructure, we didn't have legal reporting protections, and frankly, we didn't have incentives to report patient safety incidents. So in 2005, Congress fixed one of those barriers in their Patient Safety and Quality Improvement Act, PSQIA. And this law created patient safety organizations and a network of patient safety databases that had the legal protection so individuals and organizations could report patient safety incidents without fear of legal liability. Now, these actions are necessary but not sufficient for us to catch up with the aviation industry. So what have we accomplished with that? Well, not much yet. And in order to understand why, we need to understand the infrastructure that was present in 2005. So in 2005, only 4% of US physicians even had an electronic health record system, an EHR. Maybe about 10% of hospitals did. So even if we took advantage of the new legal protections and could gather data, it's all on paper. So we really couldn't conveniently aggregate it and analyze it. So enter high tech. High tech was a provision in the stimulus bill of 2009 that provided financial incentives for healthcare organizations to adopt EHRs. And as a result of high tech, US went from basically the bottom of the OECD community using EHRs to really being at the top. One, because of the penetrance of EHRs, maybe 90, 95% of us use EHRs at this point, and the comprehensive functionality we have in these systems. So all of this because of a law, high tech, which is part of the stimulus bill. Now, the reason I think this is so germane to today's discussion is because our adoption of EHRs has dramatically improved the feasibility of capturing and analyzing data related to patient safety. So it reduces the burden of collecting data. In theory, it improves the consistency and the standards with which we collect these data so that we can aggregate them and analyze them. We now have much better AI, artificial intelligence, to glean the important insights from this aggregate data. But maybe what excites me the most is because nearly all of us use EHRs, the lessons that we get out of that analysis of the aggregate data, we can actually deploy to the frontline caregivers. We can deploy those to the clinicians so they can make better decisions and make fewer errors. So that's fundamentally different. It's a fundamentally different value proposition than was available in 2005. So it doesn't matter what you could learn from aggregate data analysis if you can't deploy that analysis where it's used. So I think fundamentally, compared to 1999 or 2005 and PSQIA was passed, this changes everything. I think we now have the capabilities to make care safer, but we need the coalition, the willing, like the people who are watching this summit, in order to convert these possibilities into reality. But I think, again, we stand at a tipping point. If we choose to act, I think this glass is half full. We just need the will to do it. So thanks again to the organizers of this for giving us the impetus to take new steps to make things better.
Paul, I'm sobered by the challenges we still face, but encouraged by the increased capabilities you mentioned. Thank you for your work, your thoughtful comments today, and for underscoring that this is a matter of will at this point, not capability. Irina Papieva is with the World Health Organization Patient Safety Flagship, which is the name of the secretariat managing the new Global Patient Safety Action Plan 2021 to 2030. She's a physician and has a master's in public health. Dr. Papieva, in 2019, by resolution, the World Health Assembly established September 17th as World Patient Safety Day, and called for every nation to implement a list of proven strategies to improve patient safety. And this year, World Health Organization followed up with a powerful new Global Patient Safety Action Plan to advance improvement between now and 2030. What can you tell us about the action plan and how WHO will be working to see it implemented?
So thank you very much, dear Marty and Patient Safety Movement Foundation, for this opportunity to share one of the biggest achievements by the global patient safety community to date. Indeed, the benefits of having a strategic and coordinated approach to patient safety, addressing the common causes of harm and the approaches to preventing it, have been recognized by policymakers, political and health leaders worldwide. And in recent years, this global advocacy around patient safety has culminated in the adoption of the resolution that you just mentioned by the World Health Assembly in 2019, called Global Action on Patient Safety. The resolution, apart from establishing World Patient Safety Day to be observed each year on 17th September, urged member states and all stakeholders to recognize patient safety as health priority and address that in health sector policies, strategies, and programs, highlighting its importance within the overall context of universal health coverage. The World Health Assembly also requested in the same resolution WHO to develop a global patient safety action plan, which was done in the subsequent 2 years, and then it culminated in its adoption by the World Health Assembly in May 2021, with a subsequent formal launch in the month of August. The Global Patient Safety Action Plan strives to eliminate avoidable harm in healthcare with the vision of a world in which no one is harmed in healthcare and every patient receives safe and respectful care every time, everywhere. Our ultimate goal is to achieve maximum possible reduction in avoidable harm due to unsafe healthcare globally. The Global Action Plan provides a strategic framework for action through 7 strategic objectives and is further elucidated through 35 strategies, 5 under each of the strategic objectives. Considering that patient safety is everybody's business and requires active participation of many key partners, each strategy has been further operationalized into suggested actions for the 4 key categories of partners that are governments, healthcare facilities and services, stakeholders, and WHO Secretariat. The action plan hasn't set a numerical reduction goal, acknowledging that there is no reliable estimation of the extent of burden of harm in most of the countries. Thus, all countries are encouraged to implement their baseline estimates of safety-related performance and set their national targets to monitor implementation progress of the Global Action Plan. The plan proposes a set of indicators to support countries in monitoring and reporting progress, and it contains a set of core and advanced indicators and global targets that are aligned with the strategic objectives. Progress on the implementation of the Global Patient Safety Action Plan should be reported to the World Health Assembly every 2 years, starting 2023 until 2031. We fully recognize that countries are at different stages in their efforts to reduce preventable harm and to strengthen their national health systems. Therefore, there is no single policy, strategic approach, or intervention that can be universally applied in all healthcare settings. That is why we strongly encourage countries to adopt implementation approach to their national context. What is also important to highlight that this global plan was developed through health system strengthening lens, taking into consideration the multidimensional nature of patient safety and the need for truly collaborative efforts to achieve actionable, measurable, and sustainable improvements. So we call all member states and our partners to align implementation approach with a national health agenda within broader health system strengthening and universal health coverage context. and also harmonized this implementation approach in relation to the existing organizational structures, governance mechanisms, management processes, as well as local expertise. WHO Secretariat also has a set of very specific actions to implement in coming decades, and I would like to reaffirm our strong commitment to continue cooperating with our countries and with partners by providing high-level advocacy, strategic leadership, and technical guidance in the implementation process of the Global Patient Safety Action Plan. Thank you very much indeed.
Pat had a heart problem, and the doctor recommended that she have an implant. And the surgery in and of itself went fine, but the tenderness from that surgery never went away. And she had trouble getting people's attention.
She was pushed back from whatever the medical providers were, whether it was an inquiry at the customer desk or her post-surgical follow-up with her surgeon. They denied that there was anything wrong and that this was standard operating procedure. This is just how your body will heal.
Nobody thought it was out of normal until she became very ill. Ultimately to the point where it drove her to the emergency room.
And I'll never forget, the night we brought her into the ER in so much pain. And she was explaining to the ER nurse that she had this implant. And he's going, I don't see anything in here about an implant. I don't know. And she's going, are you kidding me? It was just down the hall 4 months ago. This same hospital. And you can't find that in my chart?
And they let her go. And it was a couple days later that they realized that she needed to come back in and that she was experiencing, I believe, what we knew at the time, septic shock.
The implant was just full of infection. When they pulled the wires out of her heart, it actually left infectious debris in her heart, which traveled to her lungs. She was in and out of the ICU 2 or maybe even 3 times in 7 weeks in the hospital.
We had the pulmonology team, the cardiology team, the infectious disease, nephrology. The nephrology team is looking out for her kidneys, but ultimately her heart was what the problem was. How was she gonna survive sepsis with a weak heart? That was never addressed.
I believe there was a lot of confusion. Things were changing so rapidly, and there were so many medical professionals involved. You need to have effective communication between family, patient, and staff. To have a printout of a pulmonologist's perspective or have a printout of what tests were done for Pat today would have been tremendous. Looking back, it's just shocking that she's not with us any longer. I think that's the hardest thing to come to terms with.
I made several attempts in order to obtain medical record. I'm not convinced to this day that I actually have complete medical record. In having others review the record, they were able to confirm that there were many components that were missing. That makes me wonder, what were you treating her for? What were you, looking at? I'm not sure. A lot of not sures.
The medical records are vague. All those phone calls, never a part of the medical records. The discussion with the technician, not part of the medical records. The discussion with the nurse practitioner or physician's assistant in the lobby of the surgeon's office, no record.
The reality is, medicine is a practice, and it's something we're practicing every day. And so we have to make sure that when we are practicing medicine, that we're working in the best interest of the client. We also got to make sure that when we're accessing medical care, we just don't rely upon our doctors. We got to look at it from multiple different lenses and multiple different perspectives. We have to ask the hard questions. We have to challenge them.
Her whole life, my mom was a fighter. She never gave up. She overcame many odds. And during her illness, she fought so hard. Her struggle and her fight and her ultimate death can't be for nothing.
Hi, everyone. I'm Donna Prosser, Chief Clinical Officer at the Patient Safety Movement Foundation. Pat Denton's story is all too common here in the United States and throughout the world. Every day, well-meaning healthcare professionals go to work and strive to provide excellent care. But when that work is happening in a disjointed, fragmented system, patients can easily fall through the cracks. And as we just heard, that can be devastating for patients and their families. At the Patient Safety Movement Foundation, we believe that we'll never eliminate preventable harm until we address these system issues. We think that every healthcare organization should be as highly reliable as other high-risk industries, like aviation, nuclear power. So in this next segment, our panel will discuss what healthcare professionals can do to advance the safety and reliability of the systems they work in and the role they play in keeping patients safe. It is now my pleasure to introduce to you the moderator for this panel, Dr. Peter Lockman. A pediatrician by background, Peter is an international leader in quality and safety. He served as CEO of ISQA, the International Society for Quality in Healthcare, from 2016 until earlier this year. And during that time, he led their transformation into one of the leading global organizations in quality, safety, and person-centered care. Currently, he's lead faculty for quality improvement at the Royal College of Physicians of Ireland in Dublin, where he directs the leadership and quality program to develop clinical leaders in quality improvement. Peter, thank you so much for being with us today. We're really looking forward to this exciting panel discussion. So I will hand it over to you to introduce our esteemed panelists and get us started.
Thanks very much. Thanks, Donna, for that and for sharing the video with us, which sets the scene for what we're going to talk about today. And I'm Peter Lachman. I'm a former CEO of ISQA and now lead for quality safety teaching at the Royal College of Physicians in Dublin in Ireland. And I've got a really great panel here with you, and I'm going to ask them to introduce themselves. I'll start with Charlene. Hi, Charlene.
Morning, Peter, and good day, everyone. My name is Charlene Hope, and I'm the Chief Pharmacy Quality and Medication Safety Officer here at University of Chicago in Chicago, Illinois.
That's great. And over to Nawa. Hi. You're coming from far away.
Hey, Peter. Yeah, I'm the furthest away. I'm talking to you from Riyadh, Saudi Arabia, where I work in King Faisal Specialist Hospital as a patient safety professional. My clinical background is in respiratory care, and my position is in patient safety, and I get to volunteer with the Patient Safety Movement Foundation as a Saudi ambassador.
That's great. Well, welcome, and I'm pleased you're with us. And then we have Pat's son, Chris. Hi.
Hello. My name is Chris. I am Pat's son. You saw the video of. It's a pleasure to be here today. I'm a licensed professional counselor. I run a private practice here in Bend, Oregon, specializing in attachment and trauma pieces. It's a pleasure to be here today with Patient Safety Movement.
Thanks. How it's going to run is I'm the moderator, and we're going to answer a few questions. And this is a very important question. As you saw in the video, one of the big problems was the lack of integration of care, the lack of sharing of information, and ultimately the lack of reliability in the care that Pat received. So what we want to really explore is how can we have healthcare workers be more reliable, and what does it take to be reliable? And those are the kind of questions we are going to talk about over the next few 40 minutes or so. So the first question I'm going to go is to you, Nawa, is this question of what is high reliability in the healthcare context? What does it really mean?
You know, high reliability as a concept is very simple. It's about doing the right thing to the right person at the right time, every single time, and under dynamic circumstances. And I think that's the last two pieces is the most challenging pieces, is where most healthcare systems actually fail is in doing it right every single time and coping with the dynamic circumstances. So to tell you an example of how reliable we've gotten over years is we all know the stories and the pictures about those items flying into the MRI machine, you know, how an oxygen cylinder flies into the MRI machine, how a ventilator flies into the MRI machine where someone gets harmed, unfortunately. And one of my favorite examples about high reliability is the great catches. So one of the great catches that we've had recently is when a nurse and a radiology technologist actually stopped the line when they weren't sure about the patient who came with a device, an implanted device, that they weren't completely sure about. So they ended up stopping the line, contacting the company, the manufacturer of the device, and ensuring that certain safety measures had to be taken prior to actually doing the procedure. And imagine, how did we move from not noticing something as visible as an oxygen cylinder to being able to implement safety measures around something that's implanted inside the patient? So I'd have to say that we've moved a long way, I think, but we still have ways to go.
Yeah, I mean, thanks for that story. And I'm going to just ask Charlene, because being a pharmacist, I've always seen the pharmacist as generally the most reliable people. They pay attention to detail and they make sure things happen. So the medication pathway is very important because it's WHO challenge this year on how to get reliability in medication safety. So could you give us some examples building on what Nawa said already?
Yes, happy to do that, Peter. The medication process, which just for our audience, really starts at the time where the physician decides to prescribe a medication to meet a patient's therapeutic goals, all the way to the point of dispensing, administering that medication, and the nurse or patient themselves monitoring, did we achieve our goal? Did that medication do what it was supposed to do, or is there side effects? So I'm going to speak in a hospital setting, and I'm going to use probably the example of sepsis, is really starting with the protocol, the guidelines. There's evidence-based guidelines that the team should be centering their care around. And this should involve all team members, not just the physician. So we should have nursing, pharmacy, the lab, even respiratory therapy. They should all come together to have a good understanding of what that protocol is. That's the starting point. That's what we call a system level intervention for high reliability care. The second thing then is to leverage all our great technology. We've got electronic medical records. We've got different alerts. We want to make sure that the technology is helping our team do the right thing, as Nora said earlier. Again, another system level intervention. Then this is where all individual team members now need to kind of execute the plan, right? We get our patient in and we're all following that protocol. But we know that there are things that are going to happen that we don't know are going to happen. This is where we rely on healthcare professionals to do that important task of reporting the events, those good catches that Nora talked about, so that we know how well is our system functioning. Is there any potential failures that we need to be looking out for? This is that individual accountability for high reliable care. And then the last step is, once we do have an event, all of the team coming together to say, why did that fail? Why did we have that near miss? Do we need to make a change to the protocol? Do we need to make some changes to our technology? Because we need to make sure, again, that we are doing the right thing for the right patient each and every time. And this is kind of those key elements around high reliable care.
And it's paying attention to the smallest detail. Chris, can I just come to you and say, what do people really expect when you go to a hospital? Do you expect reliability and then you don't see it? Or what's your perspective on that?
My perspective has been that things have changed, obviously, with the pandemic and COVID, but outside of even just an emergency room or hospital setting, I think when people access medicine and healthcare, they're expecting for it to work, that it is proven, it is tried, it's true, it's the reliability piece. What I find is most people have to remember it is still a practice. We are still practicing. We are still learning every single day. While we do have standards and protocols, I do believe it's also, they need to understand that we also, we need to work together. Every case is different.
Yeah, so the key thing here is, how can we make it reliable all the time? That means the person gets the care they need the first time, every time, no matter which clinical team is on. And that is, for me, reliability, as Nawa said. So a quick question is, for healthcare worker safety, because that's another part of it. We have patient safety, we also have healthcare worker safety. Why is this reliability piece so important? Charlene, do you want to add something there? to start us off?
Yeah, really, first and foremost, it starts with building strong relationships between our clinical teams, our hospital staff, and the leaders that direct a lot of our organizations. Transparency in terms of when we have an event, that everyone is kind of at the table to learn from the event that occurred, and everyone's kind of bringing in their perspectives as well. And that's definitely one component of high reliability care that that organizations need to continue to work on.
Yeah, constantly learning. Chris, what's your view on that, on the importance for healthcare workers?
I think that if the client is informed, they are understanding of what the medical procedure and what practice is, I think that it gives the client and the practitioner both confidence in the process and confidence in one another. And if we can have confidence as a clinician in the client, in the information provided, in the relationship, I think that we also are seeing the person as an individual. I think that that helps us provide quality care and ultimately limits or minimizes liability.
Yeah. So now in your example that you gave an example of people doing above what they normally do. They stopped the line. What does it take for them to stop the line? What was there something special with those two healthcare workers?
They felt empowered. I think they had the psychological safety to question the system. And that kind of builds on the safety piece for our healthcare providers, is that it has the two pieces where you have the physical safety and the psychological safety, and you feel psychologically safe to question the system and speak up for your patients. So they really felt empowered, and they felt that they would be supported because they brought up a concern regarding patient safety.
So I want to follow up on a quick question on that. Does everyone in the organization know the great work that those two did? There was some way that this kind of behavior was rewarded?
Absolutely. I'm glad you asked that. And you will actually find those two individuals themselves talking about it on the YouTube because we celebrated this specific, this specific great catch along with other great catches. So every quarter we celebrate great catches around the organization, where we celebrate healthcare providers who are providing, exceptional care to their patients. And in our organization, we believe that although safety is a dynamic and visible, we always believe that we need to make it visible. We need to take the effort to make it visible for everyone. So recognizing and rewarding patient healthcare providers who take the extra mile for patient safety is an essential part of the process. And as I mentioned, those healthcare providers, you'll find them on YouTube.
That's great. And actually, Donna, later on, I'll say that to be shared with everyone, because it's such a fabulous story, because it's really going to get into the next question, which is, why is it so difficult for us to have high reliability in healthcare? And Chris, just looking at that video, there were many different points I saw where opportunities were lost. Just in those 4 minutes of that video, I could start seeing where the opportunities were lost. From your perspective, could you give us some ideas of what you saw?
There are two that really stand out for me. Initially, post operation, when she was having discomfort in her chest, there was a missed opportunity there when she had accessed frontline workers and was denied care because she had an appointment later in the next week, I believe it was. That was an opportunity, I believe, in hindsight, to have discovered the sepsis before it had gotten worse. The second time was when she was cleared of sepsis. She survived sepsis, ultimately dying of a heart attack. And when they had removed her pacemaker, I believe that there was a lot of coordinated care, a lot of, whether it was electronic medical record synthesization, sorry for that term, it wasn't happening. And I think that if people took the time to just hear and understand what the complaint was or what was happening on the ground rather than a procedural standpoint, I think this could have been avoided.
So really, did anyone ask what's the matter?
They did not initially. They heard what the matter was, but they did not attend to it in a timely fashion, almost dismissing of it. And I think that there's a person-centered approach that was lost throughout that. And throughout her care, in inquiring on different components and the various medical staff coming in and out, ultimately transferring from departments, a lot of opportunity for information not being passed through appropriately.
Yeah, and the one last question I have on this, because I think the video is so powerful. I sense there's a lack of integration, not only of care, but of knowledge and knowledge sharing. Did I get the right message?
It could. When you work with, and this lends to my clinical side of pieces and having been part of coordinated care and rollout of electronic healthcare systems and what we're trying to do on a larger perspective, the technological point, we have the capability. It was just lost. We're not there yet. There's many agencies, many groups involved. Very hard to get everybody on board, even with the technological advancements we have today.
So yeah, that's really good. So I'm going to come to you, Charlene, because part of this reliability business is how we get people to behave. And I'm just thinking, I can speak like this because I'm a physician, I'm a pediatrician, so I can talk about doctors and feel that. Why is it that doctors do not follow guidelines, do not keep to it, whereas pharmacists do? And what is it about in medical care? What do you think it is?
Yeah. Actually, I do want to make a couple of comments about the video, and a couple of things that Chris said is, number one is, I think as a healthcare professional, especially working in a hospital, we still don't have a good understanding on how complex our healthcare delivery system really is. There's still a kind of oversimplification of processes where, if there is an event, well, why didn't the person just do what they were trained to do? Or, why do we just start making what seems like a simple change, but not thinking about what some of the unintended downstream consequences of that might be? So that's one of the things. And then I think a part of that, coming back to our physicians, is when we think about the history of medicine, these were practitioners that pretty much worked by themselves, right? They did not have this team. We did not have thousands of medications and therapies to treat all these different types of disease states. So it was a very simple beginnings that over the years has become gradually more complex. The second component that I know we'll talk about a little bit more in the session is the awareness that at the end of the day, regardless of all the training that we've gone through as healthcare professionals, we are human and we are susceptible to many biases, right? And that's what lends to the nurse or the physician not really listening to patients. They are thinking about all the other things they need to do, the documentation, rounding times, discharging patients on time, it's kind of all the things the organization wants them to get done as well too. So it's really a combination of those two things that sets up for not the best environment for high reliability. Now, around prescribing, like I mentioned, we've gone from, even in the 25 years I've been a pharmacist, the amount of drugs on the market has expanded exponentially. But we need to take care of individual patients that all have individual needs. And no longer can a physician say, okay, you've got high blood pressure, well, I'm going to give you drug A. They have to now think about what the clinical parts, how's your renal function, what's your weight like, what other medications are you on? That's one component of it. The second component of it is the financial aspect. Even if the doctor decides that's the best drug for you, is that medication covered? And this is a frustration of many physicians is, If a patient can't have a formulary medicine that they can afford under their insurance plan, they have to call in for a prior authorization. They have to get special permission, and they spend hours and hours on the phones with individuals who are not clinicians to get approvals for these medications. So, I think it's less the physician being unreliable, but they're physicians working in unreliable systems.
I think that's really an answer about telling about the complexity, and part of the complexity is our success, that people are living longer with more complex conditions too, and a lot of intervening. So I think that it's a strange thing that we've been successful in many things, but that's increased the complexity and causing problems. And so while you were talking there, I was just thinking about it now, that in many root cause analyses, you look to see what the cause was. Is unreliability in the care often found when you look at root cause in your root cause analysis of clinical incidents?
My God, I think that's one of the things. Root cause analysis become heartbreaking because you find all of the deficiencies in the system during the root cause process. And the thing about healthcare is that we've made processes of different layers. All of those layers are there for a reason. So when Charlene is talking about prescribing, verification, preparation, dispensing by the pharmacist, then administration by the nurse, there are multiple checkpoints there. So when you have a medication error, for example, what it means that the error actually went through all of those layers, and we failed the patient in each and every layer. But how did that happen? Often it's not something related, like if it's a medication error, often it's not necessarily related to the medication itself. Sometimes it's related to, to workload. Sometimes it's related to a human error. Sometimes it's related to sound-alike, look-alike medications. So often the process of root cause analysis really bears the system in front of you and differentiates between this individual accountability and the system accountability. And really the main focus is to try and focus on how to fix the system rather than just simply focusing on individuals. And if we fix the system, then we can fix it for the next patient.
Thanks, because that's really interesting, because it's going to lead on to my next question, was going to back to Charlene and then Chris. Is Charlene, what would it take for us to move from what is a fairly unreliable system to one that is highly reliable?
Right. I think there's three main components. The first one, and I'm going to start backwards based on Nora's comment, which is ensuring that we have strong learning systems, right? Chris spoke to this. We are all in the practice of medicine, and doing a root cause analysis, having a debriefing with a team, even proactively reviewing a process, what we call an FMEA. And I know we're not supposed to use abbreviations, but it is healthcare. These are all ways that we learn from our systems and how we can continually improve. And that really requires leaders like Nor, myself, Chris, and we're really looking at how do we incorporate patients into these processes so that we're engaging our patients in this learning system process, because they're very much a part of the healthcare team. The second one is that culture. We need to have a culture where all healthcare professionals want to speak up. They want to report events and know that they're not going to be punished for it, right? In healthcare, we still have this culture that every healthcare professional needs to be perfect. They're not supposed to make any errors. But in those failures, we are learning. And so we need the leaders of our organizations to support this learning environment with a culture that supports not only our providers, but also our patients to speak up when something doesn't quite look right. And then the last part of that is leadership. Those teams can't function unless the leaders are helping to create an environment for high reliability care to occur.
There are many ideas that have come out of there. of this idea of what we need. And I'm going to hone in on this idea of culture and psychological safety. Chris, what do you think about that from your perspective?
My brain immediately goes to more of a holistic approach to care. A lot of the times, not just client safety or patient safety, but family safety and knowledge and understanding. I think it goes right back to informed consent and understanding what the procedure is, the best procedure, what the options are, but also the clinician or the client and the family, the patient and the family being able to communicate with the doctors on what are the overarching factors that may be influencing recovery and health and impacting and exacerbating systems. I encourage people to look to the adverse childhood experience, the ACE study, and how the psychological well-being and adverse experiences and trauma throughout lifespan can impact the physical health of pieces and how those two may be intertwined. So I think we need to be asking all of the questions and looking at it from a very comprehensive and holistic perspective.
And Narwa, the psychological safety, you've given us a fantastic example of that already. What have you been doing in your hospital to engender that psychological safety? What's the magic?
Well, first of all, thank the messenger. I think that's a big part of it. So we have what we call the remodel for managing near misses, which is recognize, report, review, and revise. And the recognition part is both for, for incidents, but also applying the recognition to the healthcare providers. So we've hardwired this within the organization. In addition to that, we are in the middle of our Just Culture journey. So we've applied the Just Culture algorithm, and we've done a really huge education efforts around this to basically inform people that Just Culture is for them to differentiate between the system accountability and the individual accountability. This is in addition to a very strong root cause analysis program that's led by an executive sponsor. So we've engaged leadership in multiple processes. The newest thing is I'm working personally on our basically support program, emotional support program for healthcare providers who undergo basically the serious safety events, because they can have a really taxing effect on healthcare providers who are well-intended, but unfortunately are sometimes put in situations where a patient is harmed. So we're doing all of those efforts in addition to very strong management support to speaking up within the organization.
And are any of you doing what they call the safety two, is learning from what works really well? So not only learning from what doesn't work?
Yes, correct. Yeah, I think there are some efforts around basically sharing experiences between units. You know, what works well in this unit versus this unit. So imagine an operating room where they have multiple incidents of pressure injury. Then we sit both areas together and they compare practices. That's something that we do in multiple areas, but focused on a specific type of harm or a specific type of safety issue.
Well, that's great. So now we're on the home run, looking at the blue sky. Where do we go? How are we going to go? So each of you are going to have a chance to tell me how are we going to go forward and what do we have to do so those who are watching can get a message of what they can do next. So I'm going to start with Chris on this one. What do you think we need to do, Chris, to go to the next level?
Coordinate, communicate. Look at a person-centered approach. Talk to, pay attention to what the clients are saying. Coordinate with your peers if you're a clinician. Appropriate staffing. I think education, and educating the public about what healthcare is and what it means to access healthcare is going to work for client safety as well as for clinician safety.
Yeah, that's great. Coordination and education. Charlene, how should we deal with this complexity that you've described?
I definitely agree with Chris. When we've got really complex processes, we need the entire team involved. And, you know, one of the things that the public may not know is, you know, all of us train in our respective professional practices separately. So pharmacist goes through their pharmacy program, medicine goes through their pharmacy program, nursing goes through theirs, respiratory therapy, you know, our psychology therapy teams, we all train separately. But then we have to come into this big ecosystem and work together. And so I would say that one key thing is that we have to look at how we're educating professionals and how do we have some of our professional programs train teams together. This is definitely something that I've always promoted is, you know, I'd love organizations to have, you know, team coaches as a part of our healthcare team to help us work together as teams. That communication is always one of the #1 findings from root cause analysis as the reason why events occur. And so we still need to work on that interprofessional team building. And I think that's one of the main things I would look for in the blue sky.
I really like this idea of interprofessionalism. So the professions are not working separately, but are working together to a common goal. And by doing that, they communicate. And that requires both education, because coordination is not just going to happen. You need people to understand its importance. So I'm going to come to now. I'll ask you about system accountability versus individual accountability. Where do you see the balance lies there?
You know, I have to think that we have to really understand what happens. We have to start with inappropriate acts and then go and understand that individual failures happen often as a part of a bigger system failure. So although sometimes healthcare providers fall into incompliance, for example, but often that's a part of a bigger culture, which culture is a system failure. You know, if it's related to culture, then culture is a system. So I see it's actually with time, you know, understanding further more about our systems and understanding more about system accountability. And the more we understand system accountability, the more we create processes that account for that, and robust processes that account also for the fact that human beings will make mistakes. We will make mistakes. So we better recognize that and understand that we need to make those systems more robust and more strong to catch us in doing those mistakes and compensate for our inherited deficiencies. So I think overall, I think we're going to go to a stronger system where we understand further, and that can only be accomplished with leadership engagement and commitment, as well as full understanding from the entire organization of how errors happen.
Yeah, and I really like taking the systems approach that Pascal Carrion does in the SEEPS model, in which you look at the work system. How does the work system work from not only a physical point of view, also from a psychosocial point of view? So I'm coming to Chris on this one, is how can we get, from a psychosocial point of view, get people to feel safe, both the patients and the provider?
I go back to that word informed consent. I work too often with clients where they have had years upon therapy and they don't know what they were doing or why they were doing it or what procedure was used and why. I think, well, that is a missed opportunity, and sometimes they have been decades struggling with the same problem. So again, educating the client, letting them know that they really are their first line of defense in identifying what is happening, what is going on. An x-ray is great, but we don't always have that also for the mind, which is at play for some pieces. So looking at that from a biopsychosocial model, I think is very important in the coordination of multiple disciplines, which I believe, which was communicated here. Even this meeting here is a reminder of me today on some of the things that I need to make sure that I'm doing today and better in the long run for my clients. So it's always looking at it from that person-centered approach. And if we know what we're doing for our clients is the right thing, and we've got the time that we can dedicate to them and working with them, I think that that makes us more confident in the process overall.
And so that leads us to my final query about the psychological safety, because what we want to do is make patients feel safe, but we also want healthcare workers to be safe. And this is coming right from the start, this theme of psychological safety. Charlene, your thoughts on that, and over to you, Nawa, after Charlene.
Yeah. I was just thinking of an example recently. My sister went to the doctor, and she was talking about a medication she was going to prescribe to her, and asked my sister, well, what questions do you have for me? And she paused, asked her again. And then she said, well, if I were you, here's one of the questions you should have asked me, right? We have to continue to engage patients and inviting them to ask questions and to gain information where we are respecting the patients and in keeping their dignity intact as well too. And I just thought that was a wonderful way for the physician to engage my sister, saying, yes, you should have questions for me. Here's one to get you started that you should have asked me, and let me continue to tell you more. Just really smart. Patients and family members, again, back to this history of medicine, we went to the physician with a problem, they gave us an answer, and there was not an engagement back and forth, right? This doctor knows what's wrong with me. We fully put trust in them, but we have to help our patients understand that it's no longer this paternalistic approach. It's a team coaching approach. That physician is your coach, because at the end of the day, we have to make the decisions about our healthcare, whether we're going to take the medicine, not take the medicine, can we afford it, not afford it. So we have to help our patients along in that manner as well too, and that it's really a team that's helping that patient, and not just our physician. He or she, they're leading the team, right, and helping that patient's care, but everyone needs to be actively involved.
And Nawa, what do you think? Just briefly, quickly, as we come into the end.
I'd have to agree with both of my colleagues there. It's, great communication is key to take us forward. Also, understanding that we have limitations and challenges in healthcare, and we may have to leverage some innovation and creativity along the process and challenge existing things, challenge existing processes.
That's great. And I just want to add something from Charlene's talking is when I was a young, newly appointed attending, I used to see parents with children with complex conditions, and the social worker used to sit in with me, and she would say, doctor, what did you really mean? And she would ask those questions to prompt the parents to do so, to make sure we're all on the same page. So it took me back many years listening to you, Charlene. So we're coming to the end of this fantastic last 35, 40 minutes. It's really gone sped by. So one last comment from each of you, and that will get us to the hour. Okay, over to you. I'm going to start off with Chris.
I'd have to say self-care. If what we can do best for our clients and best for ourselves as clinicians is good, appropriate self-care.
That's great. Over to you, Charlene.
It's all about building relationships with our patients, relationships with each healthcare professional, building relationships with our leaderships that run our organizations.
That's great. Relationships, self-care, and Nawa?
I'd say safety is a dynamic and visible. It's time to make it visible.
Yeah, no, okay, so we've got a minute to go, and I'm just going to just add my bit now. I think that I've learned so much from the perspective of the therapist, Chris, also not only the son of someone who had a mishap, but really taking this perspective of saying, well, we need to think about the people who are in this relationship, the doctors, the nurses, the patient, and their psychosocial well-being as well as their physical well-being. From Charlene looking at the systems that we need to look at and how we can look at complexity and try to understand the complexity and constantly working as a team. And from Nawa, to me, I'm going to take home those two. I'm going to watch that YouTube of seeing how you can make the environment where people feel safe enough to be able to stop the line and to ask the questions. Because when I go back to that video, if there was someone who could have done that at any point in time, Chris, there may have been a different outcome. Someone stopping and saying, hang on a sec, we have to think what we are doing. So this has been really a great learning opportunity for everyone. And I want to thank all of you for your wisdom and for sharing all your experience with the people who are going to be watching this over the few days that it's beyond. So thanks very much. And I'd like to thank all of you again. Thank you.
Welcome to our patient safety moonshot panel. I'm extremely excited of the panel members we have today. The concept behind the patient safety moonshot was when we've put our minds behind something, when we really believe we could do something, be it sending a man to the moon, being curing polio, we've achieved it. And we need to take that same mindset around preventable medical harm and say we are going to cure preventable medical harm before the end of this decade, by 2030. And I'm delighted to have our panelists with us today to talk about the different areas that they're working on and things that would be necessary if we truly were able to achieve a patient safety moonshot by the end of this decade. First, I'd like to offer up to Karen to start. Introduce yourself. And the question I have for you, Karen, is you're doing such amazing work at the Jewish Healthcare Foundation around the creation of a national patient safety board. Could you share what's going on and what you've been doing in leading this effort to get us to that point?
Well, thank you, Dave. Let me say that the patient safety movement has been a terrific partner. So I'm president and CEO of the Jewish Healthcare Foundation, and we have our own regional health improvement collaborative. We've worked for 22 years to reduce medical error. We've been spectacularly unsuccessful. So moonshot, we wouldn't send someone to the moon if we depended totally on the astronauts to get there safely and get home safely. We support them. In fact, we support every pilot with advanced analytics and with excellent technology, so that a lot of the safety that they experience and they provide, if you're a pilot to other passengers, is autonomous. We don't do that in healthcare. And so one of our interests is, what does aviation have that we don't have? They have the National Transportation Safety Board, an organization that is totally focused on bringing the frontiers of technology and analytics to safety in aviation and transportation. So we said, what if we had a national patient safety board? This idea keeps coming up. I say every decade for 3 decades, but I think it's time now. And the pandemic has made it even more urgent. We should have those same protections that frontier technologies and analytics give to other industries.
Great, thank you. I want to turn to Leah next. Leah, like Karen, you've been a leader in patient safety for many years, driving Leapfrog and others to higher quality and safety measures. I'd like you to talk a little bit about the importance of aligned incentives. Your organization, as well as the Patient Safety Movement Foundation, and some others have been trying to drive that concept and raise awareness about it. Could you talk about why that's important, and especially the idea of reporting of certain safety measures that need to be increased?
Well, thank you. Thanks, Dave, for having me and for being part of this excellent panel. The Leapfrog Group was actually founded on the principle that the healthcare market should function the way other markets do, in the sense that when there's excellence, that should be paid for in light of its excellence. And when there isn't, then there should be financial penalty for that in some form. In other words, payment should be tied to performance in some way. And that is just how every other market works, but it hasn't traditionally in healthcare, as we know. And I think that's created some dysfunction. At the same time, What healthcare should do is respond to the needs of patients very directly, and patients can express their needs by choosing providers that do well. So the safest providers should be rewarded in the community by the interest of the community members in using those facilities. I mean, it's this very, very simple, fundamental framework for how you get better services in a community. And yet it's not how healthcare has traditionally functioned. It just hasn't. First of all and foremost, people don't know who's doing the best job in safety. Traditionally, we don't know that. But thanks to Patient Safety Movement Foundation, thanks to all the stakeholders really watching this, I'm sure part of today's great celebration, so many others have come together to really push to have public reporting of patient safety in a way we never had it before. And it's truly made a difference. And I'm proud to say Leapfrog has been very active in that movement. And what we've achieved is a set of measures now publicly reported that tell you, at least for hospitals, which hospitals seem to be doing the best job in preventing different kinds of events and errors and accidents that happen in hospitals. That's just really a breakthrough. We've used it to put together our hospital safety grade, the Leapfrog Hospital Safety Grade, which is an A, B, C, D, or F. We award every hospital in the country on how safe they are for their patients. Others have used those measures for a whole variety of other purposes, but payment is a really part of that too. Now, our members are employers. Employers have a role to play in addition to what we traditionally think of as purchasers like Medicare and Medicaid. Employers are purchasing a lot of health benefits, and they have a role to play in incentivizing hospitals to perform best. Now, that's not going to be the end of the equation because there's a lot more to do. And the moonshot here is for everything to be publicly reported for every setting, not just hospitals. We don't only go to hospitals, thank God. We also go to ambulatory surgery centers. We go to nursing homes. There's a whole variety of settings of healthcare, and all of them should be safe. And patients are entitled to know which ones are which. And also employers and others who can really make a difference in rewarding excellence in all of those facilities. So what we want to see is a world where there's full transparency, where we can begin to reward excellence with financial consequence. And finally, I have to say, we had to play defensive on this year. CMS proposed this year to stop reporting a number of patient safety measures, and in particular one, deaths from treatable complications from surgery, which is very important to so many of us. So many people have lost loved ones that way. And we do think that hospitals, we should know which hospital is doing a better job of preventing these deaths. So I will say, again, thanks to the partnership with the Patient Safety Movement Foundation and so many others like all of you in this room and here on this panel, we were able to get that restored, which is actually not a common occurrence that you were able to restore a measure like that. But again, we're just playing defense. We need a moonshot, and that's where we look to leadership like yours, Dave, to get there.
No, thanks, Leah. I mean, your points, just like Karen, are so important. I think of, primary hip and knee replacements when those measures were put in place to track infections in hospitals. It was many years ago, and today the majority of those cases are being done outside the hospital. Hip and knee replacements moved to ambulatory surgery centers, and the public as well as others have no clue on infection rates going on with those cases. So it's an important area. So you've heard about the importance of the creation of a national patient safety board. We've talked about the importance of aligning incentives to outcomes, not to pay for quantity and volume of procedures. The third part is I'm going to turn to my really good friend, Dr. Davila, who's been leading safety initiatives across the country of Mexico for many years and true leader. Javier, could you talk a little bit about the third area, why transparency, be it outcomes or be it preventable medical harm events, needs to increase? We need to embrace transparency and maybe even share an example, if you have one, of why transparency has made your country or others safer.
Thank you very much, Dave, and thank you so much for your kind of the invitation and Patient Safety Movement Foundation. I'm a part of all of you, and as you remember, I'm a part of the board of directors, and it's a pleasure and honor for me. And yes, this is a very important issue. I think healthcare transparency, as the Institute of Medicine states is making available to the public in a reliable and understandable manner, information on the healthcare system's quality, efficiency, and patient experience, among others, being able to share data to achieve better outcomes, quality and cost of care, for example, generating trust and a better connection with the society. Transparency can also improve quality, safety, and efficiency throughout the healthcare system, making healthcare practitioners more accountable, which can lead to better patient outcomes. Also, the importance of having the ability of clinical benchmarks that allow us to identify where we are and the aspect that we can improve and learn from other organizations. In this particular case, a healthcare culture where quality metrics have been historically treated like closely guarded secrets can be a significant challenge to transparency. Changing this attitude means changing perceptions, and workplace politics can come into play. You mentioned examples in Mexico, and I can give you one. The model of patient safety of we name Consejo de Salubridad General. It's a healthcare council in Mexico that it's a very important structure of the Mexican government. And they are giving guidance based on best practices. So organizations can improve the healthcare attention and reduce the risk for their patients. This model has been applied by public and private hospitals across the country, and they have the responsibility to give the guidance and rules for the hospital's accreditation. And they have the regulations for public and private hospitals. So this is very important for us to include this issue to transform the culture of transparency. And all the hospitals and the academies, you know that I am a part of the executive committee of the Mexican Academy of Surgery, and we are follow this guidance and regulations from the Consejo, the council, the healthcare council of the government of Mexico. This is just an example.
Oh, it's great. Thank you so much for sharing that and the importance of transparency. We've just got a couple minutes left, and I want to just really quick ask you all the same question. Karen, what can our audience do to help you in your work?
Go to our website, npsb.org. And you can do a number of things. You can join the coalition. We have over 50 organizations. I'm representing all the stakeholders in healthcare. You can tune into our podcast called Up Next in Healthcare Safety, or you can just sign on and tell us your own story. We would love to hear your story of your encounters with the health system and some of the challenges you faced.
Great, thanks. Leah, what could the audience do to help you and Leapfrog move things like aligned incentives and mandatory reporting forward?
Well, first you can go to Karen's website. We're big supporters of the board of patient safety, and you can go to Dave's website. We're big supporters as well of the Patient Safety Movement Foundation. So we're all part of the same family. And of course, you can go to our website, which is hospitalsafetygrade.org or leapfroggroup.org. Sign on to our campaigns. We've got a number of campaigns going to advance payment reform, and public reporting. That is our core mission.
Great, thanks. And finish this off, Dr. Davila, what could the audience do to help you and your initiatives in Mexico and across the world?
Well, I think, first of all, it's to be a part of transforming the culture of safety, which it means is the example of this pandemic, COVID-19, had occurred. So when I asked to my colleagues and physicians, are you still following our apps, actionable patient safety solutions? And some of them answered, well, Javier, this is an emergency situation. Let's talk about apps later. And I said, no, it's the same situation. So because we are in the same situation that in the past, the first goal is to prevent harm and to have saved our patients. So it's a very important moment to recapture the healthcare system complete in Mexico with two milestones, political and academic support. Because if the authorities and physicians and nurses and the multidisciplinary team is not involved, it's going to be very difficult to keep saving lives and for our patients and for our colleagues. So this is a very important moment for that.
Oh, thank you. And I know we're out of time. I would love to talk to all of you for another hour or two. You're doing great work. Thank you so much.